So my name is Robert Simon from the Cleveland Clinic. I'm going to be discussing malignant disorders of the pancreas today. I have nothing to disclose. So this is an outline of what we're going to be talking about. First, we're going to go over pancreatic ductal adenocarcinoma, discussing the common presentation, some risk factors, how to work it up, determining resectability, and then finally talking about treatment. We're going to move on to pancreatic neuroendocrine tumors, discussing first the types, the workup of those, and the treatment as well. And lastly, we're going to be talking about some premalignant lesions, in particular intraductal papillary mucinous neoplasms, or IPMN, as well as mucinous cystic neoplasms and solid pseudopapillary neoplasms. So first, again, we're talking about pancreatic adenocarcinoma. Generally has a poor prognosis, partly due to its late presentation and subsequent diagnosis. It's currently the fourth leading cause of cancer-related death in the United States, but that number is predicted to get worse in the coming years. So first, how these patients present. A detailed history and physical are key. It's important to ask about personal and family history of cancer, as well as signs of exocrine pancreatic insufficiency, such as steatorrhea. Unintentional weight loss is often a concerning finding, as is early satiety. This usually suggests compression of the tumor on the stomach or the duodenum. These tumors tend to grow without any signs or symptoms, and eventually present with some vague symptoms. This leads to a prolonged workup and can often delay the diagnosis and delay identifying the pancreatic cancer. For this reason, this explains why about 80% are not surgical candidates upon presentation. This is due to their advanced disease upon diagnosis. Classically, tumors in the head of the pancreas cause painless obstructive jaundice, whereas tumors in the body and tail of the pancreas tend to produce pain, either from involvement of the visceral afferent nerves or due to bouts of pancreatitis. Of note, presenting with pain is often a late finding and typically is not resectable at that point. A patient with Cavassier's sign on physical exam is when the gallbladder is palpable in the presence of painless jaundice. This is seen in less than 25% of patients. Another physical exam finding can be Sister Mary Joseph's node, which is a palpable umbilical lymph node seen with GI cancers and ovarian cancers. So listed below are some risk factors that are known for pancreatic cancer. Smoking is a big one. This increases the risk of pancreatic cancer by about 2.5 times. Smokers who have quit for more than 10 years have been found to no longer be at an increased risk. Of note, in 1986, the International Agency for Research on Cancer, the IARC, officially classified smoking as a proven carcinogen for pancreatic cancer. Pancreatitis is a chronic inflammatory process that has been shown to cause an 18-fold increase in pancreatic cancer. Obesity is in the news lately as part of the rise in cancer found in younger patients. This is true in pancreatic cancer as well, and it is attributable for a relative risk of 1.72 for pancreatic cancer. Diabetes has also been found to increase the risk of pancreatic cancer by about 82%. And there's definitely a genetic component as well. PRSS1 and CFTR gene mutations are the most common and most significant, but there are many other gene mutations, and it is actually common practice at our institution to obtain genetic counseling on all patients with pancreatic cancer. All pancreatic cancer patients should be referred for genetic counseling, as oftentimes these potential mutations can be found and help guide treatment as well as for them as well as for their family members. And then lastly, and we'll touch on this more later in the talk, but certain cystic lesions of the pancreas are risk factors for pancreatic adenocarcinoma and have been studied extensively. We're understanding more and more about them and realize the need for close follow-up and resection in certain high-risk lesions. So, workup. CT and MRI are helpful modalities to help identify pancreatic adenocarcinoma. These are usually poorly defined masses. If a CT is ordered, it should be a quote-unquote pancreatic protocol CT scan. Comparing this to a regular CT abdomen pelvis with IV contrast, the pancreatic protocol gives you thinner slices that are approximately 1 millimeter instead of 3 millimeters, and it also gives you multi-phases. So it gives you an arterial phase as well as a delayed portal venous phase. This not only helps identify the mass, but it also helps identify the relationship to the surrounding SMV and portal vein and the SMA, common hepatic artery, and celiac axis. On CT scans, pancreatic adenocarcinoma appears hypo-enhancing on arterial phase imaging. On the T1 phase for MRIs, pancreatic adenocarcinoma often appears hypo-intense. T2 flare is not terribly helpful because the tumors have a variable appearance on this phase. Also of note, there is a double duct sign that you can look for on cross-sectional imaging, both on CT and MRI, and even on ultrasound. This is where both the bile duct and pancreatic duct are dilated with an abrupt cutoff in the pancreatic head. This is not specific for adenocarcinoma, but does suggest that there is an obstructing mass in the head that needs additional workup. Good high-quality cross-sectional imaging is also important for preoperative planning because it helps you determine if there is aberrant anatomy that needs to be watched out for in the operating room. The most common pertinent aberrant anatomy that is encountered is a replaced right hepatic artery coming off of the SMA and traveling posterolaterally to the extrahepatic bile duct. Metastatic disease most often occurs in the liver and the lung. Therefore, to complete staging, imaging of the chest should be obtained. Chest CT is ideal, but at the very least, a good quality PA and lateral chest X-ray should be obtained. And if there is anything suspicious on that, then a chest CT can be performed. Tumor markers are important, in particular CA19-9. So this is important for a couple reasons. One, significantly elevated levels, some even suggest greater than 100, is suggested that there's a higher rate of metastatic disease. In addition, getting a baseline level helps determine how the patient is responding to treatment. A study out of France for patients with locally advanced or metastatic disease showed that a decrease greater than 15% had a significantly improved progression-free survival with a median of 8.3 versus 3.1 months. In addition, they had a better overall survival as well with a median of 14 months compared to 7.2 months. Another study looked at neoadjuvant chemotherapy. This study was conducted at Harvard, and they administered FOLFIRINOX, and 141 patients were operated on. 78% of them were resected. CA19-9 levels were lower in the resected patients. And of those that were resected, a preoperative CA19-9 level greater than 100 predicted a shorter disease-free survival. This can be used clinically to help guide treatment as well. For example, a level that drops after surgical resection and continues to drop with adjuvant chemotherapy suggests the tumor is responding well. If the CA19-9 stops decreasing and remains elevated or starts to rise, consideration should be made for changing the chemotherapy regimen up, as well as looking for recurrent or metastatic disease. Of note, there are a few limitations to CA19-9 as a tumor marker for pancreatic adenocarcinoma. First, the sensitivity goes down for small tumors. In addition, a Lewis blood group antigen is required to see an elevation in CA19-9. Therefore, in Lewis negative phenotype patients, which is approximately 10% of the population, they will not have an elevated CA19-9 in the setting of pancreatic cancer. Be aware that CA19-9 can be elevated in benign diseases as well, including biliary obstruction, pancreatitis, hepatitis, and thyroiditis. Staging laparoscopy is controversial whether or not it needs to be done prior to an operation. We perform diagnostic laparoscopies before all of our planned operations for pancreatic adenocarcinoma, but we do not perform staging laparoscopies anymore. This is largely in part due to the improved sensitivity and resolution of our preoperative cross-sectional imaging. Lastly, most institutions have a tumor board, and it is recommended to discuss these cases in a multidisciplinary setting to help determine a consensus for treatment. At our institution, our tumor board is made up of radiologists, medical oncologists, radiation oncologists, pathologists, and lastly, surgeons. This allows everyone to weigh in on these complex cases and determine the best way to treat these patients. So there are multiple guidelines defining resectable versus borderline resectable versus locally advanced tumors. This is part of the reason why a tumor board is very helpful. So these multiple guidelines are generally the same, but they have some subtle differences. The ones that I'm going to discuss and the ones that we typically use are the NCCN guidelines. So first, resectable tumors, there is no vein contact, or if there is contact with the superior mesenteric vein, it is less than 180 degrees. The key being that there is no distortion of the vein. In addition, there cannot be any arterial involvement. For a tumor that is deemed borderline resectable, vein contact can be greater than 180 degrees, but again, there should not be any distortion or thrombus. If the vein involvement is less than 180 degrees and there is a little distortion or thrombus, this is classified as borderline resectable. And solid tumor contact on the inferior vena cava is also listed in this group. Of note, head/uncinate lesions are classified a little bit differently than body and tail lesions. So lesions in the head and uncinate process, SMA contact less than 180 degrees, or common hepatic artery involvement without involvement of the bifurcation of the celiac axis are classified as borderline resectable, whereas lesions in the body and tail of the pancreas, celiac axis contact without involvement of the aorta or the gastroduodenal artery are classified as borderline resectable. Unresectable lesions are classified as unreconstructible SMV or portal vein due to the involvement of the tumor. In addition, we differentiate between head and uncinate lesions and body and tail lesions again. Head and uncinate lesions with SMA or celiac involvement of greater than 180 degrees or solid tissue contact with the first jejunal branch of the SMA is classified as unresectable disease. Those in the body and tail, if there is an SMA or celiac axis involvement greater than 180 degrees or solid tissue contact with the celiac axis involving the aorta, this is classified as unresectable disease. So now we get to the surgery component of the presentation. Unfortunately, only about 20% of patients are amenable to resection. It often presents too late with metastatic disease or locally advanced unresectable disease. Neoadjuvant chemotherapy plus or minus radiation has been implemented for borderline resectable disease in an effort to help downstage it and make them resectable. It also ensures that these patients receive some chemotherapy because approximately 25% of patients do not make it to adjuvant chemotherapy after a pancreatic duodenectomy. This is likely due to the high morbidity associated with the operation, including decreased functional status. There have been some advocates, though, that even patients that are in the resectable group from the get-go should undergo neoadjuvant therapy. There's also the train of thought that giving chemotherapy neoadjuvantly helps assess the tumor biology. So for example, if the tumor progresses on neoadjuvant therapy, then this portends a poor prognosis anyway, and patients likely would not have benefited from a big operation. There are studies being done to help look at these questions further. In particular, a randomized controlled trial is currently underway to look at a neoadjuvant chemotherapy for resectable disease and has completed patient recruitment and is waiting for follow-up. Of note, resection rates after neoadjuvant chemotherapy range from about 50% up to about 90%. Chemotherapy regimens consist of FOLFIRINOX, which is oxaliplatin, irinotecan, 5-fluorouracil, and leucovorin. Another option is gemcitabine. Resection is indicated if there is no disease progression to follow-up imaging. If radiation is given neoadjuvantly, it is important to operate 6 weeks after the completion of the therapy. The reason for this is because the radiation continues to have treatment effects for approximately that long, and if one waits longer, then the effects wear off and the patient is at higher risk of progression. Also, it tends to cause significant scarring and makes resection more difficult if the operation is after 6 weeks. Surgical options obviously depend on the location of the tumor. For tumors in the tail of the pancreas, a distal pancreatectomy is indicated. If this involves the celiac axis and they have a patent gastroduodenal artery, this may be amenable to an Appleby procedure, where the celiac axis is ligated off of the takeoff from the aorta and the common hepatic artery is ligated to separate the tumor. For lesions in the head of the pancreas, a pancreaticoduodenectomy or a Whipple operation is indicated. The first pancreatic head resection was performed by Dr. Koch in 1909, but was popularized by Dr. Alan Oldfather Whipple in 1935, of whom only performed 37 in his entire career. It was initially a 2-stage operation, with the first stage creating a cholecystogastrostomy, a gastrojejunectomy, and transecting the common bile duct distal to the cystic duct. Approximately 3 to 4 weeks after the first stage, the second stage was then performed, where the second portion of the duodenum was resected with the pancreatic head, and oversewing of the pancreatic duct. Of note, the pancreas was not sewn to the jejunum. A modern, quote-unquote, Whipple operation is now a single-stage operation where the entire duodenum is resected with the pancreatic head and the common bile duct. The proximal jejunum is then brought up into the right upper quadrant and anastomosed to the pancreas and bile duct, and a loop of gastrojejunectomy is then performed. A few variations on the theme are performing a pyloric preserving Whipple, which has been shown to have lower rates of marginal ulceration as well as lower rates of dumping syndrome or bile reflux, but has a higher incidence of delayed gastric emptying. Another option is to perform a pancreaticogastrostomy as opposed to a pancreaticojejunostomy. Theoretically, this has a lower leak rate, but has higher rates of delayed gastric emptying. I want to also talk about vascular reconstruction for pancreatic surgery for adenocarcinoma. There are a multitude of studies that look at the feasibility of resecting the portal vein, and there are a variety of techniques, including primary repair, placing a patch, a segmental resection with primary end-to-end anastomosis, or a segmental resection with an interposition graft. The question becomes, is it worthwhile to do this big operation on top of an already big operation? And the studies have shown that if an R0 resection can be obtained, i.e. that all microscopic disease can be removed with clear margins, then doing a vein resection has the same outcomes as an R0 resection without a vein resection. This cannot be said for arterial resections and is therefore not recommended at this time and is not standard of practice at our institution. Some tips and tricks to keep in mind during a Whipple that you suspect is attached to the vein is to take the time to put vessel loops around the portal vein, splenic vein, and superior mesenteric vein, as well as all other branches, prior to the dissection of the uncinate process off of the portal vein and SMV. This way, if bleeding is encountered, proximal and distal control can rapidly be obtained and the bleeding controlled. In addition, there is a SMA first approach that can be performed where you take the tumor off of all structures and you take it off the SMA first. This leaves it only attached to the vein, which can then be resected. Staging for non-metastatic disease can only be done post-operatively to truly identify the size of the tumor as well as the lymph node positivity. T1 tumors are less than 2 centimeters. T2 tumors are between 2 and 4 centimeters. T3 lesions are larger than 4 centimeters. And T4 tumors involve the celiac axis, SMA, or common hepatic artery. Studies have shown that lymph node positivity negatively affects survival. N0 equals no lymph nodes are positive for malignancy. N1 disease correlates to 1 to 3 lymph nodes positive, and N2 disease is more than 3 lymph nodes. The staging system is fairly straightforward. T1 tumors are 1A, T2 are 1B. Sorry, let me do this one again. So now we're going to talk about staging of pancreatic adenocarcinoma. For non-metastatic disease, this can only be done post-operatively to truly identify the size of the tumor as well as the lymph node status. T1 tumors are less than 2 centimeters in diameter. T2 tumors are between 2 and 4 centimeters in diameter. T3 tumors are larger than 4 centimeters in diameter. And T4 tumors involve the celiac axis, the SMA, or the common hepatic artery. Studies have also shown that lymph node positivity negatively affects survival and is therefore very important. N0 equals no lymph nodes are positive for malignancy. N1 disease correlates to 1 to 3 lymph nodes being positive, and N2 disease is more than 3 lymph nodes being positive. The staging system is fairly straightforward. All T1 tumors are stage 1A. All T2 tumors are stage 1B. All T3 tumors are stage 2A. If lymph nodes are positive, then it is at least stage 2B. If it is N2 disease and T4 disease, those are stage 3. Stage 4 is any metastatic disease. Of note, 5-year survival rates are dependent on stage, and as you would expect, get worse with increasing stage. As you can see, the 5-year survival rates for stage 1A is approximately 39%, 34% for stage 1B, 28% for stage 2A, 21% for stage 2B, which means that they have some lymph nodes that are positive, and 11% for stage 3. So these are the treatment regimens that are considered for adjuvant chemotherapy. The PRODIGE 24 trial looked at resected pancreatic adenocarcinoma, and patients received either gemcitabine or FOLFIRINOX. This was a randomized, controlled, multi-institutional trial. FOLFIRINOX was shown to have improved disease-free survival. 3 years was 39.7% versus 21.4%. And overall survival was 54.4 months versus 35 months in the adjuvant setting for pancreatic adenocarcinoma. Of note, there were significantly more adverse effects, and therefore not everyone was able to tolerate FOLFIRINOX. The number of grade 3 and 4 adverse effects for FOLFIRINOX was 75.9% versus only 52.9% for gemcitabine. Some of these major effects were severe diarrhea, vomiting, peripheral neuropathy, and fatigue. So now we're going to talk a little bit about pancreatic neuroendocrine tumors. These are rare tumors, although pancreatic neuroendocrine tumors were found in about 10% of the population in a post-mortem study. The reported incidence is expectedly lower at about 0.2 to 0.4 per 100,000 individuals. There's multiple types of neuroendocrine tumors. The first being non-functional. This is the majority of pancreatic neuroendocrine tumors. Approximately 70%, although some studies have found it to be as high as 85%. These can be associated with von Hippel-Lindau, MEN type 1, neurofibromatosis, and tubular sclerosis. There's also functional neuroendocrine tumors, such as gastrinomas, insulinomas, glucagonomas, VIPomas, and somatostatinomas. So in gastrinomas, there's an elevated gastrin secretion. This causes elevated levels of gastric acid, and sequelae from that are severe peptic ulcer disease. Often, multiple ulcers from synchronously as well as unusual places, such as the second and third portions of the duodenum. This syndrome is called Zollinger-Ellison syndrome, named for two surgeons out of the Ohio State University. A serum fasting gastrin level greater than 1,000 is diagnostic. For indeterminate levels, a secretin stimulation test can be performed. This was first described in 1972 by Eisenberg. This involves administering secretin intravenously, which normally causes gastrin to decrease. But in patients with gastrinomas, their serum gastrin levels will increase. Serum gastrin levels peak at 5 to 10 minutes after the administration of secretin. Therefore, they should be measured at these time points. A talk on pancreatic neuroendocrine tumors isn't complete without discussing the gastrinoma triangle. Put simply, it is the triangle where most gastrinomas are found. The triangle is made up of the neck of the pancreas, the junction of the cystic duct and common hepatic duct, and the junction of the second and third portions of the duodenum. This helps intraoperatively when trying to identify where the location of the gastrinoma is. Other types of functional neuroendocrine tumors are insulinomas. This is when there is unregulated insulin secretion that causes severe hypoglycemic episodes. Whipple's triad is the classic syndrome associated with the tumor. This includes hypoglycemia with neurogenic symptoms that resolve with eating glucose. This can be diagnosed by measuring an insulin to glucose ratio in hypoglycemic patients, and if the ratio is greater than 0.3, then they are likely to have insulinomas. C-peptide suppression testing can also be performed to confirm this diagnosis. Glucagonomas are where glucagon is hypersecreted. Glucagon has the opposite effects of insulin. It helps regulate serum glucose by promoting gluconeogenesis. The classic symptom is necrolytic migratory erythema. These patients also get diabetes mellitus and diarrhea. Glucagon levels can be measured in the serum, and levels greater than 1,000 are diagnosed. VIPomas, in these types of tumors, patients get diarrhea. These are diagnosed by plasma VIP levels greater than 1,000. Lastly, somatostatinomas. Somatostatin is known as the great inhibitor, and therefore these tumors suppress lots of GI hormones. This can lead to glucose intolerance, steatorrhea, hypochlorhydria. It can also cause gallstone formation due to biliary stasis. Elevated levels of serum somatostatin are found. In order to work up these tumors, a detailed history and physical is extremely important. These patients often present with vague symptoms, and taking a good H&P is important to help diagnose the problem, as well as help determine if they are functional or non-functional, or if there is a familial component to them. Tumor markers are important to help diagnose. Not all of these need to be performed. This is where a detailed history and physical can help. A chest CT is important to help stage these tumors, as well as good cross-sectional imaging of the abdomen and pelvis. And if you are suspected for metastatic disease, an octreotide scan or a dotatate scan, which are nuclear studies, can help identify extra pancreatic sites of the disease. So on cross-sectional imaging, neuroendocrine tumors tend to be well circumscribed with smooth edges. On ultrasound, they look hypoechoic. On CT scan, they appear hypervascular. Large tumors can even have a cystic component to them. These tumors tend to have a capsule, and they displace the surrounding tissue instead of invade it. Thus, these are less likely to cause obstructive jaundice or exocrine pancreatic insufficiency or pancreatitis compared to pancreatic adenocarcinoma. On MRI, T1 phase, these are hypointense. On T2 phase, these are hyperintense. And on T1 phase with contrast, these appear hyperintense. Octreotide scans depend on the somatostatin receptor characteristics of the tumor. For example, gastrinomas are more sensitive than insulinomas. There's a newer dotatate scan which is available and is more sensitive than an octreotide scan, but of note, more difficult to get covered by insurance. Often they require a negative octreotide scan with suspicion of metastatic disease before they will consider paying for it. There's a study out of Australia from 2012 that showed that clinicians gained additional information with dotatate scans in 83% of patients that had already gotten an octreotide scan. So there is some benefit to them. Of note, 75% of patients have metastatic disease on presentation, most commonly to the liver. So now we're going to discuss treatment. Surgical removal of pancreatic neuroendocrine tumors is recommended for functional tumors to help relieve symptoms from excess hormone production. It is also recommended to help relieve symptoms due to tumor compression of local structures. And lastly, resection is indicated to help prevent progression of disease. Current NCCN guidelines for non-functional pancreatic neuroendocrine tumors recommend non-operative management of those less than 1 centimeters with serial imaging and resecting those greater than 1 centimeter. There is some controversy with this approach though, as some societies advocate resection for those greater than 2 centimeters and observing those between 1 and 2 centimeters unless they express high-risk features, such as high Ki-67 index or a high mitotic rate, or if they were poorly differentiated. Therefore, it is important to present these indeterminate patients at a multidisciplinary tumor board to help identify which patients need to go to the operating room and which ones are safe to monitor. Of the surgical options, surgical enucleation should only be attempted in benign lesions, which is really only insulinomas or gastrinomas that are less than 2 centimeters. Otherwise, formal resection should be performed. Tumors larger require formal resection because it becomes difficult to avoid the pancreatic duct. These operations include a pancreatic duodenectomy for those tumors in the head of the pancreas, a distal pancreatectomy for those in the body and tail, and also a central pancreatectomy for those located at the neck of the pancreas. Neuroendocrine tumors are unlikely to invade surrounding structures and therefore are less likely to require vascular reconstruction. But if they do, similar to pancreatic adenocarcinoma, if you are able to get an R0 resection, then these vascular reconstructions should be performed. Of note, in malignant neuroendocrine tumors in the body and tail, and a distal pancreatectomy is required, and a splenectomy should be performed to help prevent metastatic disease or recurrence of disease. Intraoperative ultrasound should be utilized liberally to help identify the location of the tumor, the extent of the tumor, as well as the relationship to surrounding structures, such as the vasculature and the pancreatic duct. Ultrasound can be used in the operating room to assess the liver as well. This helps to look for sites of metastatic disease that you cannot necessarily see on preoperative cross-sectional imaging. There are multiple different probes and techniques to use. For laparoscopic surgery, the rigid probe or flexible probe are available. For open cases, the hockey stick probe or finger probe are probably used the most frequently. Whichever one the surgeon feels most comfortable with, there's no benefit from one to the other. Due to the fact that the pancreas is thin and the tumors are often superficial, it can be difficult sometimes to get a good picture of the mass. Therefore, knowing how to do a saline standoff technique can help. This entails placing saline around the lesion of interest and utilizing its good sound transmission characteristics to lift the probe off of the surface of the pancreas and project through the saline. This gives a buffer between the lesion and the probe to help with resolution of superficial structures. Another way to achieve a good view of superficial structures on the pancreas is to place the ultrasound on the stomach and view the pancreas through the stomach. Malignant neuroendocrine tumors can metastasize to the liver. Now, if this is the only site of metastasis and the entire tumor burden can be removed, then there is benefit to long-term survival to resect the sites of metastatic disease in non-functional pancreatic neuroendocrine tumors. This includes wedge resections of the liver, formal liver resections, as well as microwave ablation of the tumors and hepatic artery embolization. A combination of these resection techniques and ablation technique can also be utilized. For functional tumors, there is even some literature stating that if at least 90% of the tumor bulk can be resected, then there is a benefit to the patient, and surgery should be pursued, even though they know they cannot get the entire tumor burden out. Chemotherapy options are limited, but include somatostatin analogs. Of note, if you think that the patients are going to need somatostatin analogs, a cholecystectomy should be performed intraoperatively, as well as if these patients may need hepatic artery embolization for metastatic disease. The last part of this talk is going to be dedicated to premalignant lesions, or lesions that put patients at an increased risk of developing pancreatic adenocarcinoma. The ones that we worry about the most, that we see the most, are intraductal papillary mucinous neoplasms. With better and better CT and MRI scans and the increased rate of ordering of such tests, for a multitude of reasons, we are finding more and more incidental pancreatic cysts. This is tricky because some of them do have a malignant potential. Therefore, it is important to differentiate between the bad actors and the good actors. Let's start with one of the most common types of cysts that we see, IPMN. There are three main types: main duct, branch duct, and mixed type IPMN. We often use the Fukuoka guidelines. They are updated every 4 years, most recently in 2017. Main duct IPMN is defined as segmental main pancreatic duct dilation greater than 5 millimeters with no other causes of obstruction. Branch duct IPMN consists of cysts that are greater than 5 millimeters that are in communication with the pancreatic duct. Mixed type IPMN meets criteria for both main and branch duct. To help differentiate between the bad actors and the good actors, we have defined worrisome features. These include pancreatitis, cysts that are greater than 3 centimeters, an enhancing mural nodule that is less than 5 millimeters, and a thick enhancing cyst wall. Main pancreatic duct dilation from 5 to 9 millimeters, an abrupt change in pancreatic duct diameter with distal pancreatic atrophy, lymphadenopathy, an elevated serum CA19-9, and lastly, a cyst growth rate greater than 5 millimeters in 2 years. There are also high-risk stigmata that are also concerning for malignant degeneration. These include obstructive jaundice, an enhancing mural nodule greater than 5 millimeters, and a pancreatic duct dilation greater than 10 millimeters. Here's an algorithm that it can be used based off of the Fukuoka guidelines to help determine management of these pancreatic cysts. We utilize this in our institution. In addition, we have a multidisciplinary conference every week to discuss difficult cases. One can't mention pancreatic cysts without mentioning how to differentiate one from another. When an endoscopic ultrasound and FNA is performed, CEA and amylase levels are obtained, and this is one component that helps distinguish the cysts. CEA levels greater than 192 suggest mucin-containing cysts with a sensitivity of about 79%, and elevated amylase levels suggest communication with the pancreatic duct. Therefore, knowing these values should help figure out what type of cyst is what. IPMN will have elevated CEA and amylase levels. This is because they contain mucin and they connect to the main pancreatic duct. Mucinous cystic neoplasms will have elevated CEA because they contain mucin, but they do not connect to the main pancreatic duct, and therefore there is no elevation in amylase. Pancreatic pseudocysts will have an elevated amylase because they are connected to the duct, but they do not contain mucin and therefore will not have an elevated CEA. Lastly, serous cystadenomas will have no elevation in CEA or amylase because they do not contain mucin and do not connect to the duct. Measuring glucose in the cyst fluid is a newer technique that can also help identify mucin. If the glucose is low, this is more suggestive of a mucin-containing cyst and is another data point to help improve the accuracy of the diagnosis. The sensitivity of glucose is 92% and the specificity is 87%. Mucinous cystic neoplasms are another premalignant lesion. The female to male ratio is approximately 20 to 1, with a mean age of diagnosis of about 40 to 50 years of age. These are typically large cysts that are lined by columnar mucinous epithelium and are not in communication with the pancreatic duct. Ovarian stroma is required to diagnose mucinous cystic neoplasm, as is not found in any other pancreatic neoplasm. On CT scan, they appear round or oval. Calcifications can occur in the periphery. They are heterogeneous and they have internal septations. There is a definite and significant malignant potential in these lesions. It is usually quoted as about 15%, but has been reported to be as high as 50%. Some studies quote somewhere in between at about 36%. Some of these studies include carcinoma in situ and some do not, which may represent the discrepancy. But either way, the malignant potential is high, and therefore surgical resection of all mucinous cystic neoplasms is recommended. Enucleation can also be considered in lesions less than 2 centimeters without any solid components because these have been found to have such a low malignant potential. In addition, lesions greater than 2 centimeters are difficult to enucleate without getting into the pancreatic duct, as we talked about in the neuroendocrine tumor section. The risk of recurrence has been quoted as 0%, and therefore no follow-up imaging is needed after resection. Of note, serial imaging has been suggested as a reasonable option in small lesions without any solid components because of their low malignant potential. In lesions less than 3 centimeters without mural nodules, the malignant risk is 3%. Approximately 20% of these will progress to require surgery. That being said, current recommendations are to remove all mucinous cystic neoplasms due to their significant malignant potential, but on a case-by-case basis, watching these is acceptable as well. Lastly, I want to talk about solid pseudopapillary neoplasms. These are first described in 1959 by Gruber-Franz. The female-to-male ratio is about 10 to 1 with a mean age at presentation of about 22 years of age. These also have a malignant potential, quoted to be about 15%. Liver is the most common site of metastatic disease. On cross-sectional imaging, these appear hypervascular and well encapsulated. They are round, and they have both solid and cystic components. The solid and cystic components are due to the fact that they can bleed into the tumors. These are predominantly in the tail of the pancreas. They tend to grow and can cause mass effect on surrounding structures. It is rare for them to cause jaundice because most are in the tail, but they can cause mass effect on the stomach and colon, causing early satiety, nausea, vomiting, abdominal pain, and even bowel obstructions. Again, surgical resection is the mainstay of treatment due to their malignant potential. Even in the setting of metastatic disease, surgical resection should be performed, including debulking of the metastases. Local recurrence can occur, and therefore close follow-up is needed. Even if recurrence does occur, it is still recommended to undergo surgical resection. Long-term survival is quoted at 95%, even in the setting of metastatic disease.